There we go. Good afternoon, everyone, and a warm welcome from Centurion here in Pretoria. I missed you all last week. I was definitely having a braai. In fact, I was having a braai on the beach down in Ballito. I did not do the Jerusalema, but hopefully some of you did, according to our president. I do hope that some of you had the luxury of having a well-deserved break, even if it was just a long weekend. But welcome back, especially on this first day of October. And can you believe it? We've only got 92 days left to make the absolute most of 2020. It's been a challenging year. Let's not kid. But yeah, let's see what we can do for the next 92 days. I want to focus on today, however, and let's see what we can achieve out of this webinar about improving the healthcare consumer experience. And we've got two guest speakers with us again today, which I'll introduce in just a minute. I want to share some statistics with you of who's sitting next to you virtually in today's webinar. So we were lucky enough to get over 650 people that registered, and a warm welcome to each and every one of you. Psychologists, nearly 200 of you. OTs, spot on with 60. Physiotherapists, spot on with 100 of you. We've got 40 bios. There's 48 speech and audiologists, 25 dietitians. There's a list of podiatrists, medical orthotists and prosthetists. There's social workers, chiropractors, optometrists. There's nearly 30 of you. We've got a handful of doctors with us. There's registered counselors, social workers, and hearing aid acousticians. I think in total there's 18 disciplines, if I'm not mistaken. So it's fantastic having everyone here. A great big thank you to the SpaceNet Global Group, obviously, again, for sponsoring this afternoon's webinar. And I'm very proud to say that it is, in fact, our 21st webinar. So it's great to celebrate this occasion as well. A big thank you to Wendy. She's sitting behind the screens, and her team from the Dux Academy of Healthcare, who's managing this webinar and is also responsible for getting your CPD certificates out to you via email. You should receive that within the next week or so. Wendy, thank you so much for all the hard work and effort that you put into everything single Thursday afternoon again. And thanks for getting this webinar accredited as well for One Ethical CEU. I see there are still people joining us, and we often get asked the question, where can I find any of our previous webinars? Now, guys, I am happy to say, I'm just going to open my Q&A and my chat functionality, that you can access any of our previous webinars via different platforms. I'm quickly going to copy it here, and I'm going to paste it in the chat functionality for you so that it's easier for you to access. And that is definitely via our website. There's a podcast and also our YouTube channel. So please go and listen to them, whether it's via podcast or look at the video as well. I'm not sure whether you're sick and tired of looking at our faces week after week, but at least not sick and tired of our messages, hopefully. I see there's still a few people coming in. We'll wait for them to settle down, but I am conscious of the time. So I do think we need to slowly kick off. Otherwise, we're going to run out of time. And we need to wrap up at 5 o'clock again. I've got a few introductions to make. Let's start with Prof. Siegel. He's definitely new to this panel. Prof, first of all, very, very welcome, and thank you for putting some time aside to join us. Oh, Prof, we can't hear you. Perhaps while he's sorting that out, Prof was kind enough to send me his CV, but it would take the whole hour if I had to go through that. But I would like to share with the attendees that Prof. Siegel is a pediatric endocrinologist, and he's a diabetologist, and he's also the chief medical officer at Guidepost. Now, he qualified at WITS quite a few years ago, obviously, but he was at the Cleveland Clinic in Ohio for 3 years. He did his fellowship in pediatric endocrinology and diabetology at the Indiana University School of Medicine, and he's an honorary professor both at WITS and the Northwest University. But Prof, I think what really stands out for me is that you've got such a passion for research, and then especially translating that research into practice for both patients and providers. And thank you for coming to share some of your wisdom and your knowledge with us this afternoon.
Well, it's lovely to be here, and I hope you can actually hear me now. So
yeah, that's better. I think your volume is still fairly soft, but we can hear you.
I'll fiddle around here.
No worries. Guys, a very familiar face, obviously, to the screens in front of you is Dion Beers. Dion, the Director of Profnet Medical and the SpaceNet Global Group Executive for Operations, and definitely one of the people with the most passion about delivering healthcare in a new and refreshed way that I've met in a long time in my life. So, Dion, thank you again for joining us as well this afternoon.
Thank you, Lonnie, and hi, Prof.
For those of you that don't know me, my name is... Yeah, it's getting there. It's better. It's better. For those of you that don't know me, and I think you all should by now, my name is Lani Ace. I'm a qualified physiotherapist, actually with Dion many moons ago. And my professional journey took me from South Africa to abroad for over 12 years, to back to South African soil because it's absolutely in my blood. And currently I'm a product manager with the SpaceNet Global Group. And I'm very honored to be your host again for this afternoon. Guys, please sit back, but do join in the conversation by using the chat functionality. You can also use the Q&A functionality, and both myself, Dion, Prof as well, if you can manage. We'll glance at it, so it's not as if I'm being distracted. I'm just keeping an eye on some of the questions that might be coming in from you, and we will try and pose that during the webinar this afternoon. As you know, it's a nice informal discussion, and hopefully we can keep it that way. But I do want to start off by addressing a question to Prof. And something that came into my head as I was coming back to work on Monday, and I was on holiday for a week, was wherever you go, whether you're on a holiday, whether it's the radio, whether it's a newspaper article, whether it's online news, it doesn't matter where you look, where you listen, where you are. You hear about COVID, and I think we're all getting pretty tired of it. Now, I'm not underestimating COVID. Please don't get me wrong. I know it's extremely serious, and I know we're not out of the woods yet. But surely there are some lessons learned, especially in the healthcare environment, that we can compare pre and during COVID versus what we should be doing post or after COVID. And perhaps, Prof, you've picked up on some of these lessons, and do you care to share some of those with us?
Yeah, sure. I mean, you're right. We are getting a little bit tired. And I mean, I don't know if it's just lockdown that made us tired, or it's not going away as quickly as we wanted it to go away. And it's not going to go away. So let's just be honest, let's face it. But I think what it has done is it's uncovered a whole bunch of, I think, silver linings that we can take away from COVID. And the lessons to be learned both in practice and in how consumers are interacting with healthcare professionals, how professionals are interacting with healthcare consumers. So choices that are being made, new platforms that are being used, and a shift in focus, I think, mostly towards health. So typically our ecosystem or the healthcare system has really been focused much more on disease management, with very little on how do we get reimbursed for managing health? How do we actually decide that nutrition and exercise is a core part of what we actually need to commit to? I think everybody knows that there's been a little bit of weight gain associated with lockdown, which is one of the unintended consequences of lockdown. I've heard rumors, and I've sometimes even seen people that sneak in and have that complaint that their fridge and their cupboard did become their best friends during coronavirus lockdown. So that has been a problem. But I think what it's done is it's shifted the focus to how do I get healthy? Because the coronavirus has taught us one lesson, is that there's an underlying risk that is attached to inflammation. Inflammation by lifestyle diseases and lifestyle choices, both in the short term and the long term. So we need to start addressing the risk factors, not just the disease management itself.
Dion, would you agree with that? You want to challenge that statement?
Yeah, absolutely. No, I agree with that. And I think the elements that have most certainly moved us and forced us into thinking about things differently is not just about healthcare and how we approach that, but everything. How we embrace technology. We were forced almost in a way. You'll hear from companies that have survived and got through lockdown. And many of them start off by saying, we were able to successfully deploy our staff and allow them to work remotely during a level 5 lockdown. And that meant you could continue with life. And we also see it with our kids' education, doing online schooling. And we see it also in health being moved into these areas where we're actually adopting technologies that have in fact been there for some time. But it's that adoption curve, just being a bit behind in that adoption curve, both as healthcare practitioners as well as patients. And here suddenly we see that there are tools that are actually not as daunting and as difficult to use as before, or that we perceived. And now that we've actually utilized them, we're realizing this is actually something that we should be considering going forwards. Something that has certainly changed the paradigm really about how we're going forwards. But it's not just those elements. There's other elements of technology too that we've absolutely embraced. Rolf?
Yeah, no, I couldn't agree more. I mean, the same thing with this practice. I mean, I practice still every day, and we had to pivot very, very quickly to being able to doing teleconsults, Teams consults, and you realize that there's a different shift in the way that you have to deal with a person. So you have to spend a lot more time setting up a consult. So before, you would have a patient sitting in your waiting room, they'd walk in, and they knew if you were running a little bit late because their consult actually started the moment they walked into your building. Now you start running a bit late and you're late for a Teams meeting or a Zoom meeting, and you've got to let people know you're going to be late for them because they can't induce that or deduce that. And then also you have to actually be prepared for that consultation. You have to, in my world of diabetes management, make sure that there's data to interpret and that you've seen it in advance and you can both share it and look at it at the same time. Before it was immediately in your hands in your rooms. Now you have to make sure that that's available. Otherwise you don't get anything out of the consult. We have to worry about Wi-Fi connectivity and data and sound quality and pitching up on time and having an agenda and some kind of structure to what you do. And what it starts teaching you is that there's structure and process that are required to generate the outcome. And it really made us learn that very, very quickly, that without it, people didn't show up on time, they couldn't connect, they were late for calls, and there wasn't data to discuss. So you really had to shift towards what does the structure of the new processes look like? What are the processes I've got to follow to execute? And then what are the outcomes that we're going to measure from doing those things? So it's kind of in a rapidly accelerated the quality control in the healthcare space, it just into a microcosm of a practice, for example, and one consult.
Interesting. And I think we often talk, when I speak to healthcare colleagues of mine, healthcare professionals, many of them are saying they're obviously on the forefront. Most of them have actually contracted COVID, those that I've spoken to. And then there's obviously that conscious sort of concern around, do I open my practice to patients coming in because I am going to be exposing myself? Have you also picked up that there are patients that are reticent to actually come in for the same reason? So you're actually having both sides that are concerned about in-contact consultation. And what is that like now?
Yeah, so in the first few weeks of lockdown, when there was a lot less knowledge around and the misinformation that is out there and has been out there for a long time, especially around diabetes, the message went out, diabetes patients are vulnerable, they're at risk. But I run a predominantly type 1 diabetes practice in the practice setting, and then a guidepost, we mostly deal with adults with type 2. And those risk pools are completely separate. Type 1 patients are usually young, fit, don't have any major comorbidities, and they are not at risk of coronavirus. Where you look at the type 2 population who've accumulated lifestyle diseases, age being the #1 risk factor, combined with cardiovascular disease, hypertension, inflammation, and suddenly you've got two completely different populations, and the one is very, very happy to stay away. The other one is staying away more for misinformation, and the ones that were staying away from the practice, even though you set up your practice to be as safe as it could be, were really there because of either misinformation or they were worried that they would contract something that they'd bring home. So that they were staying home and out of schools and other things, just that they didn't bring it home to a vulnerable person, which was the right thing to do. But at least we could set up to still manage the chronic diseases effectively. But it's back to normal now. I must admit, it's back to normal. I think people are loving getting out again and having that interaction again. We still do the interspersed teleconsults where people now live remotely and they're much more set up to do remote consultations. So today I've done consultations in East London, one in Cape Town. Yesterday I did one in Zimbabwe. So it's opened up a whole world of possibilities to manage your patients without getting them to travel hours and hours at extreme costs to get the same job done.
Now what has that done for? Sorry, Lonnie. Sorry, Lonnie. So what has that done then for the traditional approach to say I need to find a healthcare provider near me? Obviously, geography was important then when you're actually getting in your car and driving there. Going to a bricks and mortar practice to actually consult to your closest dietitian, physiotherapist, biokineticist, GP, rather than going to, a pool of dietitians across the country and specifically finding somebody that might be more aligned with your specific healthcare needs. Did you find any changes in that behavior?
Well, I think what it does is it opens up all of those exact possibilities. Is how do I find a healthcare practitioner, even if they're remote? I used to be limited by geography, but I'm not anymore. I can now go on the internet. I can search to find a physio, for example, who deals just in the problems I want to deal with, or a nutritionist who focuses on low carb. I can now find that person. And if I'm not in the same geography, I can still do an initial and follow-up consultations without losing anything. So I think it's completely opened up the marketplace. Okay. And also what it's done is you've got consumers starting to shop around for what they want. And then their own values and needs need to be met. Otherwise, they're going to continue shopping around. So really, it's opened up consumerism in healthcare, which I think is a good thing because it will drive, A, volumes, I hope, but B, also the ability to play at the top of your game. And you've got to be the best. Otherwise, you're not going to stay in that space. You're going to get edged out by somebody else who is playing the A game.
And you're not being seen because you're not seeing patients only because you're the only physiotherapist in the Dorpy, because people can now fish further abroad than that in other ponds, right?
Right. But I think it also opens up opportunities for healthcare practitioners who specialize in particular areas. Because, I mean, for example, I'm stuck in Joburg because if I had to move to a smaller place, there's no ways I've got the volume of patients that could support a pediatric endocrine practice, for example. Right. But if you have a special interest in something, you've now got the whole country to open up to. So if you market it appropriately and you offer the services that get them coming back, it really opens up opportunities to start connecting positive interactions in the healthcare environment that generate outcomes.
And in fact, not just in the country, but internationally. I mean, they had the HPCSA clarifying for us on one of the previous webinars that provided you're registered in the country you're practicing from and in the country the patient finds himself, you are also able to then engage in using technology in that treatment and treatment. Yeah.
Absolutely. Yeah. I was wondering, Prof, during the stricter lockdown levels, patients that avoided care at that stage, do you think that they actually did harm to themselves potentially because they try to manage their own health care? I mean, let's use diabetes as an example, because they're too scared to go to a doctor or a dietitian or a bio or a podiatrist, whoever the case may be. And instead of engaging potentially on a different platform, which they could have done if they wanted to, they caused harm. Is that a possibility?
Definitely, yes. So, I mean, there was harm, A, in the lockdown process. Usually, you already have a condition where weight was an issue and increased your cardiovascular risk, your insulin resistance, and the likes. But also, you purposefully avoided going into a lab to get an A1C, for example, to see if you needed a therapy intervention or not. You stayed away from monitoring and screening for other complications. You didn't see eye doctors. You didn't see foot doctors. So there's no doubt that we're going to see a little bit of a backlash from people who've avoided routine care and to their detriment. So only the most self-efficacious of those people who were already good at managing their own conditions would have continued doing a good job. The others, I think, all would have decayed to a degree.
Sure.
Unfortunately.
That is a concern. Yeah, I'm just very interested, and I think these are some questions that came up in previous webinars is from the participants, is that how successful can you really engage and manage a patient remotely? And I know you've had experience in Guidepost and in other forums where you've got multiple different disciplines right across the allied healthcare spectrum. I mean, if we have to put a list together of all the professionals involved in the diabetic care, I think we'd easily get to 15. But how effective are they really in managing if you're not actually having the patient in front of you that you can touch them and assess them and engage with them?
I really think it does depend on what kind of services you're providing and how much you really need to have had at least a face-to-face visit to, for example, teach somebody how to do their own foot care. Right. You could then subsequently move that to an online consultation with video cameras and the likes. Yes, you can't feel a pulse and you can't, but you can still gather a lot of information about a foot from a video camera and by talking to your patient. In other disciplines, I mean, there's been loads of people setting up physio and biokinetics approaches for remote training and monitoring. And in fact, a lot of the patients really loved it because their family members could join in, usually at the same consultation. And right. The whole family started getting a little bit healthier and more engaged in that. And because they didn't have to travel, they could do it at a time that was more convenient. And sometimes the engagement was even higher than it probably would have been in face-to-face. Mm-hmm. So I think you've always got to look at what have you built to facilitate that offline engagement or distant remote engagement? For example, at Guidepost, we do very, very detailed histories and connect telephonically with patients with diabetes. And we really understand their context and spend a lot of time taking a detailed history. And we know their medications that they're on, their comorbidities, and really get a good idea of what a day in their life looks like and where their journey has been. And I think that's one of the things that's gone missing out of medicine. For me, one of the most important parts is the connection between one caring human being and another. Just that connection gives you better outcomes because there's belief that gets created. There's a trust that gets created in that therapeutic relationship. And then you start adding additional value on top of that. And taking a history is the most important part of any part of medicine, is taking a decent history, followed by a decent physical exam, and then lab tests and special investigations. But because you're stuck doing telemedicine, it opens up that ability to listen for gaps. Are you connecting, waiting to hear responses back? You get to learn quite a lot more. And often people will tell you stuff they'll never tell you in a face-to-face visit. They'll tell you over a phone. So it really opens up opportunities to learn and connect in a different way. And human beings like hearing other human beings. They like connecting and seeing other human beings. But it doesn't have to be direct physical contact. And I think a lot of people who come to Guidepost don't believe it can be done via a telephone. But actually, the results are great, and they really do connect. It's
I think
great to see.
Neil Kinsley from Medici actually raised that and said, everyone's always scared of telehealth or telemedicine, but it goes right back to Alexander Graham Bell and the invention of the telephone. So I'm glad you used the example of telephones, because that's about reaching out and providing that continuity of care. I don't think it's a replacement of care, but it's a continuity of care and an accessibility to care. So that I know I don't need to, book myself in. It's going to take a 3-month waiting list, drive through, take time off work, and all of the rest. I've got an issue right now that I'm concerned about, and I know that if I address it as a patient now, the potential for complications or unnecessarily going through to see my healthcare practitioner might be allayed from that. Just through that reassurance, that quick assessment, or hang on a second, this is quite important. You do need to come in and see me. And I think part of that whole journey is also the coaching element. And I use the word coaching carefully because I don't want to degrade, I think, the formal healthcare practitioner-patient relationship. But the coaching and the mentoring and the walking that journey with the patient is often, I don't know in your experience, but is a huge contributor to the success of that patient, knowing that I've got somebody I can turn to around my levels of activity, my nutrition, and the pain that I'm experiencing, and how I manage that and walk that journey, knowing that I can actually engage in a formal and professional way. But at the same time, I'm not limited to having to get into my car and having a bricks and mortar in the flesh conversation, right?
Exactly. It does open up frequency of contact, which isn't always possible in a face-to-face consult. You might have limitations in the number of visits you're going to have, for example, but that doesn't exist in telemedicine. You can set up a call a week from now and another week, because often you have that breakthrough moment with somebody and you need to maintain that momentum. But if you only see them 6 months from now, the momentum's gone already, and nobody really supported that behavior change that you just had the breakthrough with. And that's the advantage as well of telemedicine and these other approaches, is you can have that small frequent contact, either via a WhatsApp or an SMS or a telephone call or even a video call, where you can maintain that momentum and keep building it until you achieve the outcome. And because we use electronic health records and we map and do data-driven consults, it's so easy to see that the thing you did resulted in the thing you wanted. So you start getting this feedback loop that you get reassured that the interventions you're picking and the problems you're solving are being solved. And that teaches you medicine. It teaches you that you're getting better at doing what you're doing if you start seeing the outcomes. But also the person you're managing starts believing that things they do make a difference. And so many people are disempowered. They never believe that they have the ability to control complex conditions. But diabetes is a very manageable condition. You've just got to be taught how to do it, for example. And so with so many other things, but you want to see the reward. You want to see some return on investment for that sacrifice you made or that decision you made. You want to see a return on investment. So that ability to have fast looping cycles where you get to see input, return, and movement towards a goal, and that progression is unbelievably valuable for creating belief and getting behaviors entrenched that actually work.
That's incredible. And I think it applies both ways. I mean, we're talking about a patient, and I'll carry one of these around with me all the time. I wear it, I sleep with it, everything, because it tells me my sleeping patterns, my kilojoules that I've been burning through the day, my calories, my activity levels, resting heart rate. And I find that quite encouraging to be able to benchmark and objectively follow that, and actually even get a heads up to say I'm about to get sick because my resting heart rate's moving. And I can actually have a heads up on that. So you start understanding your own health as a patient or a consumer of healthcare. But I think even more importantly for us, I think, as healthcare professionals, is that we're also able to iterate the process. So if your outcome measures are giving you objective outcomes, that you're able to see, I've tried the following intervention and these are the outcomes I'm getting. But if I change this to this best practice guideline or this approach or the latest evidence I've seen, rather than just trying to do a sort of an assessment from my patient subjectively, I can actually see changes to outcomes that are objective. And you're continually looping that back again about what is your best practice approaches and what in fact works for this type of patient versus that type of patient.
Yeah, exactly. But it's our learning cycle too. So what these new platforms offer is two things. One is volume. So now you can start doing more of what you're really good at and passionate about. So you're more likely to get engaged as well. And your learning cycle or your return cycle is brief enough or short enough that you can still measure the outcome. Because a lot of the things we do might last 1 or 2 weeks, but if you see them again in a month, you've missed that chance to see that you'd changed the trajectory of where you were going. So having those shorter cycles and more frequent contact definitely enhances our learning ability too.
To make it a bit
outcomes and measurements and things like that. And I know we touched on this during a previous webinar as well. I think, Dion, it was last week when we spoke to Hannes van Aswegens, and we started speaking about ecosystems, sick care versus healthcare versus disease management, that sort of thing, and the importance of measurements and outcomes. Prof, I presume this is something that you regularly use at Guidepost. You've got stipulated measurements and outcomes that you try and achieve, track, capture data, because data is absolute key here, I feel.
So we have a custom-built electronic health record, but it's not just an electronic health record. It's also a system tool that has all the frameworks built in that are evidence-based. So when you're coaching a patient live, you have frameworks that you're already following in the system that allow you to do best practice medicine. So you're never lost. You always know where you're going in the journey, but also because we've got a patient relationship management program, when you get entered into the system, you can't fall off the system. As you close one task, you have to have booked the next task. So we've got a whole journey map that you can follow, and we know exactly where you are in that journey at any given time. But we can also monitor because we capture, not exactly. So the patient gets reports at the end of each consult. They're the ones who collect the data and see changes in their blood sugar patterns, which for many of them, they've never seen that before. They've never appropriately collected blood sugars in a format or structure that allowed them to see any relationship between a decision they made and an outcome reflected in their blood glucose. So for us, it's about showing people the data. But for many, learning and understanding blood glucose data is incredibly hard, and it takes a long time to really do it. So what you've got is you've got a coach who looks at that data and understands all the braille and then tells you the story back again in a language that you really understand. And we also do first language coaching. So for many patients in this country, it's the first time they've ever been taught diabetes in their home language, and by somebody who understands their culture and actually lives in the same area. So it really does start adding to the ability that geography is no longer a limitation. We can start playing to the strengths of what you can really do when you understand the job that needs to be done, and you can start building things that you need to do and then measure as you go along. So we measure blood glucose data, hemoglobin A1Cs, weights, and other metrics, and then also all the other general screening procedures as well. But we also know we're measuring how you are doing, not just in terms of actual measurement, but we also know what your psyche is doing, know what your level of coping is doing. We're knowing all of those kind of things because we can see it in your engagement, how often you schedule a consult or reschedule a consult, or how often you would move out a consult, for example, how quickly you answer the call. We ask for customer feedback after every single consultation, where they have to rate the coach interaction and rate their journey with Guidepost. So we monitor and measure a lot. And you're right, that data is just sitting there. We've got millions and millions of recorded blood sugar points. We've got over 1 million recorded minutes of voice conversations with patients about lots and lots of things. It's just data goldmine.
But Prof, I think before we get to the data and that goldmine, because I've got a probably quite an inflammatory question around that. But before we get to that, it sounds like what you're saying here is that you've got multiple various healthcare professionals engaging on this patient journey. I mean, you're speaking from an endocrinology point of view as a clinician, but I can hear you've got a very close association to the various role players that rally around the patient in a very well-structured interdisciplinary approach. How do you find this electronic health record and these almost staged or stepped or best practice guideline approaches? How do you find that impact between the communication between the various disciplines themselves too in coordination of care?
So we would love to build out even more communications with the role players in the healthcare journey of a person with diabetes. So currently we've got a diabetes coach, but we've also got coordinators who facilitate the interaction between a coach and the Guidepost platform, so that they tee up consults, make sure that you arrive on time with data, and all of those settings are right. So we can maximize the time that the patient is actually investing in giving to us to help them manage their conditions. So we've got to maximize that. But also, we know that there's journeys out there that have to happen as well. So for example, we need to see a nutritionist, we need to see a biokineticist or a physio, or get you to your podiatry care. And sadly, our ecosystem currently is mostly the coach and the coordinator. What we really need to do is build out this ecosystem that says, we can't be doing anything. We've got visibility of your journey, but we want to be helping you navigate to the people in you or around you at times that are appropriate for you and in the dose and the sequence in which we're going to get value. So sometimes some patients aren't ready to see an allied health professional because they just aren't there in that space yet. But when the time's right, you need to be able to make sure that that consult happens, but not just one. A person might need to do 8 consults in a row to get the outcome. So how do you know how to link them up? And that's what virtual healthcare also allows you to do, is that ability to have those 6 or 7 or 8 consults that we know at the end of this process we get an outcome. But a funder paying for only 1, because that's what your basket of care said, it's never going to give you an outcome. We know 1 can't give you an outcome. We need to have 6, but at the right time, the right intensity, and doing the right interventions, that will give you your outcome. But we also know that based on this medicine and this context and this lifestyle issue and these other comorbidities, this is the intervention you've signed up for, because we've discussed it with you in a shared decision-making process. You're now ready, you're primed, you're more knowledgeable, and you're ready to engage and learn. Now you have much greater chance of success with that intervention than you might have had if somebody just said, oh, go and see so-and-so, and it could be in May or November next year. Who cares? Nobody really facilitated that interaction to tee it up to give it the best chance of success.
Yeah, fantastic. I think you've touched on a point there that we will loop back closer to the end of the webinar and give a URL as well. But as ProfNet, we're very keen to get an indication from the attendants, the participants here, on expressions of interest to actually be part of these virtual networks, to expand that out and become part of these coordinated care programs. So we will allude to that a little bit later. But I'd like to just come back, Prof, to your points around outcomes, measures, and data. I mean, we all know data is the new oil, I think is the expression I've heard before. But it's so crucial that the oil is sitting in the correct hands. As you're collecting this data, where do you feel this should be sitting in ensuring that we drive healthcare outcomes and quality forward?
I think the people who are collecting data need to be very careful about what they're collecting, and they're not just collecting data just for the sake of collecting data. But also we use the data to interpret journeys through our systems. We get to know what's working, what's not, and we're iterating. I mean, we're on software version 180, I think, already. So every week or two, we are releasing an update that takes learnings from what our coaches have found on the system, what our patients are telling us, what the coordinators are telling us, and we keep building it in to the system to enhance the experience, both for the person delivering the healthcare through the platform, as well as for the person receiving the care on the other side. So it's not just data for the purpose of collection of data. It's knowing exactly what you want to collect and then using it appropriately. There's so much more we would love to collect and use, but sometimes you just resource constrained.
Yeah, what I'm hearing is that you using the data. You're not necessarily sharing that data with a funder, an insurer, a payer, whoever that might be.
No, it doesn't go to them. It stays in-house. We might share anonymized pool data on like A1C levels or average blood sugars or the other stuff, but the other internal data stays inside our database.
I think
And
we
we look at it all the time. We monitor and measure outcomes and processes and journeys. And okay, you're 120 days into your journey. Where do we expect you to be by now? Where do we expect you to go? So that's where the coaches are really good. They know about diabetes. They know about behavior change. They know about journeys. They know where you are and where you need to be. But you have a specific context that is unique to you. Your beta cells are different from somebody else's. How many you've got left, how they're functioning, what comorbid conditions and complications you have, what medicines and medicine interactions you have, where you work, what you eat, how often you eat, and who you're eating with. We need to know all of these things because we can we know where you want to go, but the route you've got to take to get there and the obstacles you're going to face in getting there are completely different from somebody else. So it's not just about being on the right drug at the right dose. It's about facilitating your journey and navigating it to where you need to be and helping you and equip you with the skills you need that if we left you alone, you could carry on with your journey. That's one of the major goals we have at Guidepost, is to improve self-efficacy so that by the time you've left the program, you carry on your journey, you're doing more and more of your own decision-making.
Sure. Based on the actual insights you get from the data, right?
Correct.
I think that's the key part, and we saw that in a McKinsey report, is just relating to actionable insights that we are able to get out of the data to inform both the healthcare professional as well as the patient on what those next steps are, how they're performing, is the intervention working, and how close are they to their targets that they're looking at to get themselves out of a risk pool or onto the front foot as far as disease management goes. But I think from a data point of view, what is really important for us is that this is a personal passion, but I think it spreads through our business, is that the data really is a cornerstone in assisting in driving the professions forwards. And I know we have a lot of leaders here from the various societies and associations that join us on these webinars. And really our appeal to you is, let us know if there's any way that we can assist you to gain and gather and report on data. Because it is my strong opinion that this information should be aggregated and brought through to the various representative groups, associations, societies, so that they can have meaningful conversations with various role players, whether it's Department of Health, whether it's patient groups, whether it's funders or administrators, where they can have meaningful conversations that are backed and empowered by data. Right now, we're having conversations about, this intervention is great because hopefully the evidence says so, but at what outcomes? And what is the value that that's bringing? And then we say this intervention will cost this much money and the patient might need 10 sessions. But then what? Are we measuring what impact that has actually had on the patient's outcomes? I always use the example of somebody going in for a hip replacement. And they're not going in for a hip replacement. They're going for improved function and a pain-free existence. They want to be able to function and live. But post-hip replacement, we're not always measuring these things and saying, well, have we actually achieved independent function? Can they climb stairs up and down? Can they get back to cycling that they did before? Can they walk around without pain? Can they get back to work and integrated back into society? And those measures need to be put together with, this is the impact of this interdisciplinary team or these disciplines at the following cost, because then you can justify and motivate for those costs to be appropriate value, not a price war on trying to get a race to the bottom on pricing, but to say this is the value of the services being offered and this is the price that's attached to that outcome. Not just the fact that I've done a certain procedural process, but you're being paid for that outcome or paid for that value that's being delivered. And that's the exciting area we need to be in. I believe that doesn't sit with anybody. It doesn't sit with Profnet, it doesn't sit with SpaceNet, it doesn't sit with an administrator or an actuarial group trying to analyze this. It's my belief that should sit with the associations and society so that they can have those meaningful conversations about the value of their profession. That really, to me, is utopia.
And I think the societies and the associations need to endorse these measurements. They need to highlight what needs to be measured in certain disease groupers, if I can put it that way, and then start following best practice. And yes, of course, practice for patient A and B is not necessarily the same, but that's where there's always swings and roundabouts. And you, as a team of healthcare professionals, that's how you navigate the patient's journey. And the patient needs to know step by step where he or she is tracking in that journey. And I think that's how you get the patient to on board and engage and take responsibility for their own disease.
The concern I have in the lack of this type of outcomes data in the right hands is we can see already that we rapidly moving to alternative reimbursement models, not the fee for service. In other words, I did this process, I did this movement on a patient, and so there's a code for it, and there's a price that goes with that. That's our fee for service model. And as we move to fee for value or fee for outcome models, whether they're global fees or whether it's a per diem rate or whether it's a capitated rate, all of those elements, we're flying blindly if we've only got claims data on that one. We need to be saying, what is the fee for value and how do you measure that value? And unfortunately, I think the power base is currently sitting in an actuarial kind of analysis rather than a health outcomes analysis. And we need to correct that and at least be prepared with the data so we can have, again, meaningful conversations around fee for outcome and value. Otherwise, we're going to be one hand clapping.
And I think part of the problem with that data collection is that people will collect the data that they've got available. And they'll collect the easiest measure that there is. It might not be the best measure, but it was easy to get. So that's the one that everyone chose to do. Yeah. So we need to build measurement into the processes that we have so that we start collecting the right data right from the first step. And then we will start collecting the right measurements, not just settle for the one that can be measured.
Yeah. Now, Prof, Lani, I'm going to zoom back out. So maybe just ask your question. I can see you.
No, go for it.
Okay.
There's a question that came up or a comment about coaching. So surely if a healthcare provider forms part of one of these bigger networks to look after a patient with a specific disease, let's use diabetes, not every single healthcare professional is a specialist in treating a patient with diabetes. There needs to be a level of coaching, training, hand-holding, mentoring throughout this process to upskill healthcare professionals. And I think that responsibility also sits with the necessary associations or societies to achieve the necessary outcomes.
Exactly. And it is about finding people who are passionate about that field, because they will automatically commit more time and energy to learning. And a lot of what we do isn't reimbursed. It's just we do it for the love of medicine and the love of patients and the love of getting outcomes. So you commit heavily there. And that's where you want to say, well, I don't like doing that part of diabetes, but I much prefer doing this part of diabetes, for example. Or you might want to do diabetes reversal, for example, as a nutritionist and focus on keto and ultra low carb and low calorie approaches. But you want to see more and more people, because only through seeing more and more people going through that journey and understanding their experiences and their outcomes do you get to tailor your advice and learnings, because nobody's an expert at these things. The only way you can become an expert is to do more and more and measure the outcomes. And if your outcomes are getting better and better, and the process is better and better and quicker and faster, and the patients enjoy the journey, then guess what? You've just created a good service. But you're only going to do that if you get the volumes. And you're only going to get the volumes if you commit to being really good at doing that thing. So you have to really give up some other things. Nobody's going to be the perfect generalist. It doesn't exist. But also you just want to do what makes you happy every day. And that will make your patients happy every day.
Absolutely. Also putting your hand up and saying, I am good in X, Y, and Z. And I can prove it to a certain extent. And make it visible, make it known that this is your interest.
So, for example, with our coaches, we've got diabetes nurse educators who registered nurses. We've got dietitians or nutritionists who've done advanced courses in diabetes. They've already gone and done masters and diplomas in advanced diabetes management. They've already said, this is an area I'm passionate in. But now give me a platform that I can practice my skills at. And the advantage of being on the platform is we can send them patients from all over the country. They don't have to leave their bedroom, for example, to actually do all of these consults. They don't have to wait for somebody to refer a patient to them. They're the best educator there is, but unless you're geographically located and you politically or appropriately connected to the referral pathways, you'll never get feet through your door. So this opens up also opportunities for running practices where you can see volume. And we've got a training platform. Every coach that's come onto our platform has learned more and more as they've been on the platform, because we learn, we teach, and we continuously upskilling our coaches. And there's peer coaching amongst them. I do a lot of coaching for them, but we are all getting better. And I've learned a lot through this process. And I learn every single day I'm in practice. I learn from the patients every single day. Yeah. And keeping an open mind about that, that's what makes you want to get up every morning and do this, because I love learning and I love teaching. So it's the perfect thing to do. But you have to commit to doing that.
Yeah.
Yeah.
Prof, there was a question in the Q&A there, just about, it's all good and well to look at a multidisciplinary approach or interdisciplinary approach, but how in reality, how do we really get this to actually happen? And I think there's various ways. I'd love to hear your practical experience on that. But from our point of view, I think what is important and where we definitely focus and where we play to our strengths is using technology to enable these environments. Having an electronic health record that travels with the patient, that you can communicate, and it doesn't have to be as big as it sounds. I think everyone's waiting for this massive thing to arrive. That's the electronic health record that's driven by the government, and without that, we can't do anything. We'll stick to paper. There's steps we can take where we actually got a record that various disciplines can access, not the whole record, but the elements that are appropriate for the various disciplines. And that's managed, obviously, within POPI agreements and arrangements and regulation, as well as HIPAA compliance, in fact, that we're using. But that you can share that information, because that allows the coordination of care between the various disciplines. Centralized report writing and saying, well, here's the occupational therapist report, the psychologist report, and putting that together in a coordinated way, having team meetings on a weekly basis with the patient in the meeting, where the patient is driving the care and saying what are their concerns, their pressures, their next steps, their targets, their goals they want to achieve. And that team rallying around the patient to assist them and their families to move forward. So I think it's organizational. I think it's technology enabling these spaces and linking practices together in virtual networks, or be them even in the same bricks and mortar, but linking those together so that the actual team can actually function together as a team and not just isolate and come in and do the physiotherapy, and then the bio comes in and does the bio, but they don't know what each other is doing. It's really down to communication, isn't it? And how do we actually empower that through technology?
And it's not just backwards communication, it's forwards communication. So if I send you to a nutritionist, I need to know that that nutritionist got exactly the same game plan I do, and that they're fully aware of all the same care journeys and the care plan that we have for you as an individual. They're on board with that. And then you've got an alignment automatically. So there's information going in one direction and backwards again. And also, because you're working in a network and everything becomes visible to that network, the whole network gets to know where you're going. So everybody's getting upskilled on how things should be done and could be done. And then suddenly you've uplifted the entire quality of the network, because everybody's starting to see movement towards the goal and knowing how they're contributing to it. And you might leave diabetes coaching for a while and say, listen, we need to do a nutritional intervention. That's the biggest gap that we've identified. I'm sending you away. You're going to have 6 or 7 sessions with a nutritionist, and then we'll touch base again. But I know if I referred you in this direction to this nutritionist, and this is the outcome I was expecting, I know when you rejoin again, I'm going to know exactly where you are. It's not going to be a surprise to me that you didn't get what I thought you were going to get. And that's why having everybody communicating and knowing what service you're going to get is so critical. And that's why we need people who are passionate about doing diabetes, for example, connecting to a network and saying, I want to be part of a diabetes network. I want to know that I'm creating and contributing to this journey. And I'm also learning from everyone else in the ecosystem as well. Because it's all possible, and we have a shared learning.
What's happening in the ecosystem.
Maybe I could use this moment to just appeal a call to action, because I think we're seeing in the Q&As and in the chats, people are saying, so where do I go to centralize the data collection? What do I do to actually create this multidisciplinary or interdisciplinary approach? So we've been holding back on it, but I see that Wendy has put up the URL there. And what we've done is take an initiative here. There's no cost, there's no commitment, there's no T's and C's, there's nothing else there. But what we're trying to do is just get an expression of interest. We'd like to know from yourselves as participants, as well as your colleagues, please share that far and wide. Is all we're trying to understand here, and we're taking a small slice of a big ecosystem. And I think, David, I would like to ask you this now to speak about your ecosystem and what that means, or what doesn't mean. But what we're doing is taking a small slice of this and saying, well, let's take this thing carefully, and saying, in diabetic care, whom of you are interested and passionate to drive your services into a diabetic care program that is coordinated? And all we're looking for is an expression of interest. If you go to that pcn.profnetmedical.co.za, and Lonnie will put it up in the chat as well. There we go. Thanks, Lonnie. If you click on that, it'll actually just take you through a very simple wizard, just to get to know what your discipline is, but it's an expression of interest in diabetic care. We'll later on add other network kind of approaches into that space. But right now, looking at diabetic care, we'd like to know whether you're a psychologist, a podiatrist, a physiotherapist, occupational therapist, whatever it might be, a nurse. If you're interested in diabetic care and you want to rally around the care of those patients, from an education point of view, being empowered from that, from a data point of view, a systems point of view, as I say, there's no commitments. What we're trying to do is just get an idea of where the practices are, how big is that footprint, and how can we start bringing that network into the ecosystem. So please, again, there's no strings attached. We're just trying to understand an expression of interest. Go to pcn.profnetmedical.co.za and run through that wizard. It'll probably take you 3 minutes tops, and then we can start having communications after that. And seeing how that works. Sorry, I'm getting a thumbs up here from my developer saying it is live and ready. He was under time pressures and got it live and ready. That's why we've only put it up now. So please go for it, and we'd really be interested to see who's interested in diabetic care. But David, from your side, how are we looking as far as ecosystems? What do we mean by that? We've spoken a lot about all these bits and pieces that have to sit in a bubble, which we want to call an ecosystem.
Right. So if we think about the healthcare system, it's not really a system, and it's not really about health, and it wasn't really about care. I mean, if you really measure each of the components, it's like, well, it wasn't about health, it was actually about disease, and there wasn't a hell of a lot of caring going on all of the time. From a patient perspective, it was completely fragmented, and then there's absolutely no system. There's nobody who built our ecosystem. There's no major governing plan. If we really think about how healthcare grew, every little niche player in that ecosystem managed to grab a little foothold. And that's how, and the way they survived is if you weren't generating income out of it, you were never going to survive. So what did it land up being? It lands up being an ecosystem built from randomness to allow players in the ecosystem to profit from people with disease who need disease management. Let's be honest. And that's not the place we want to be playing in. We want to actually play in a space where the ecosystem actually is beneficial to all parties. So a funder knows that in that ecosystem, value-based outcomes are going to happen because they're funding it. There has to be some funding in this ecosystem. Then there's got to be the players in the ecosystem who are all in it for one motivation. Yes, you want to survive and thrive and do well, but you also want to participate in the generation of a valuable outcome. And the only way that can work is to start. If we look at a silo approach, which is what's been built on this fee-for-service model where everybody's competing with everyone else, nobody wants to give up anything. But you have to start communicating because you need to navigate some people this way through an ecosystem and others through these touch points at these times with these values being created. So you have to have some navigation and some overview of the system. So you need measurement. You need to know where a person is in their journey at any given time. You need some form of shared communication, and you need a baseline funding for this ecosystem. But really what it is, it's about getting each component of the system to work together with another component of the system, whether they saw it or not, towards an outcome. Because the outcome is a product of the parts and interactions between the players in the ecosystem. If everybody's just doing a free-for-all, you're never going to get the outcome. You might have the best components, but unless they got clipped together in the right sequence, in the right dose for each patient, no outcome will be generated at a per person level, and therefore at a population level, you're going to miss it too. So it's really about getting visibility of where everyone is and what they need and getting them just what they need when they need it. Really, nobody's built this yet. It's going to get built.
Well, we're busy, right? And I think this is a point to maybe declare some interest here is that, you know, we have chosen and we're working with Guidepost very closely to build out on this ecosystem, both locally and internationally. So, I mean, we're very excited about it. It's very early days, but we're very excited in working with you to make that a reality and to keep building out on that. So it is most certainly exciting times. But yeah, I think the next steps are slow, steady steps about eating this elephant one bite at a time and seeing how we can actually start organizing, coordinating within that ecosystem, right?
And it starts with measuring interest. It starts with knowing who in the ecosystem wants to play in this kind of a model, and then rewarding them and facilitating them and upskilling. And the other reward for this is once you're in this ecosystem, you can go to very big players of healthcare delivery and say, put 10,000, 20,000, 100,000 lives into this mix. We will navigate them to the people who they need to be seeing. So there is a huge reward. Because often when you're geographically remotely located and you have other issues that limit access, suddenly all of those barriers in a virtual network start falling away, and people can arrive at your door with services needing being done. And that's, everybody's going to sign up for that at low cost.
Absolutely. And I think that the important part to me in all of this as well is that we're not looking at an outcome that is the absence of sickness, but an outcome that is the presence of health and wellness and vitality. And I don't, wellness and vitality is often overused words, but I think moving the cheese to a position where we're saying we're trying to protect and manage people's health, because we don't currently work in a healthcare system. We take care of sick people. That's a sick care system. So how do we change that paradigm? How do we actually rally people around an ecosystem that first and primarily focuses on looking after and protecting someone's health before they're sick? And then if they have risk factors, how to manage those risk factors so they don't get sick? And if they do get sick, how do we manage that as not the center, but then that's the next circle out. And then if they're actually living with a chronic disease, how do they manage that and actually get good quality life outcomes from that? So it's that whole spread out rather than putting sick care in the center, but putting health care in the center. And I think that's crucial to the model, because it actually breaks the whole traditional medical model, doesn't it?
Yeah.
Exactly. I mean, the way I always look at it is just briefly, it's like a pinball machine. Yeah. If we've got a pinball machine and you've got people with diabetes, and there's 400 million people with diabetes in the world, if you pull one of those little balls into the pinball machine, it's going to bounce around and eventually it will fall through the paddles and die. But it doesn't matter. You just pull another one through because there's like 399,999,000 left. So that's the problem, is while it was bouncing around in the ecosystem, the current ecosystem is there that every touch point extracts value and offers very little in return, sadly. What we really want to do is learn how to play the game where every touch point adds value and you never get to fall through the paddles. You actually win from a high score, but it's the patient's high score, not the healthcare system high score.
Sure.
That's what we want to build.
What a brilliant analogy. That is beautiful. I just want to see that there's a couple of chats coming through, and maybe it's easier just to say this, is that we got an overwhelming response on logging onto pcn.profnetmedical.co.za. Many of you are ProfNet members or StressNet members or EasyMed users or DAXA members. Use your credentials for that. That'll log you in, because it will pick you up as already registered because you're part of the StressNet group. And if you've forgotten your password, there is a forgot password, and that'll then just fire that off to you. So just for those who are obviously doing that. Sorry for that interruption, Lonnie.
No, that's absolutely fine. I'm just watching the clock, you know me. And I think, maybe as a lasting thought from my side, I think we need to get an ICD-10 for being healthy.
Now you're talking.
Because it doesn't exist.
Yeah.
It doesn't exist. But gents, we need to start wrapping up, unfortunately. We've got about 2 or 3 minutes left. And I am going to circle back to both of you for some closing remarks. But just a quick reminder, please attendees, go and register again for next week's webinar, same time, same place. When you log on to easymed.solutions, you will see it's a brand new website. You can still navigate to the webinar tab and you will find the registration form there. And please let us know what you think about the website. It's got a really fresh look and feel to it. And I'm really enjoying navigating through all the pages. The topic of conversation next week is going to change slightly, and we thought it wise to maybe do a series of webinars, maybe 2-3 weeks in a row, as people and healthcare providers are coming out of COVID and they're opening up their practices and trying to get it up to 100% utilization. There might be people considering a fresh start. I want to start my own practice. I want to merge with someone else and maybe we start afresh, or there's someone that's going to be qualified, come next year. They've done ComServe and they want to start their own practices. So we thought it wise to present a series of webinars to start, set up, grow and market your practice, and even thinking further down the line. If you want to sell your practice, what needs to be in place to do that eventually? So next week, we're going to talk about the business of establishing a successful healthcare practice. It's both the creating and the setting up of the practice. And Dion, I think we've got an interesting guest speaker joining us. Am I correct?
Absolutely. We've decided we're going to dilute this physio dominance in the panel. Bertie Haps will be joining us. He's the Vice President of the Biokinetic Association of South Africa. He's the incoming president. He'll be president at the end of the year. And we're really excited to have him on the panel. He's confirmed just a couple of hours before this webinar. I'm so excited to have him to share some practical experiences about setting up practices and running those. So we look forward to that.
Wonderful. Definitely looking forward to that. Thank you, Dion. And I know you will be joining us as well because you've got a wealth of experience in that field. So, Prof, thank you so much yet again for spending time with us. Dion, you too. And if I may sort of sneak in a question here, are you prepared to perhaps join us on another webinar in maybe a month or two's time?
Anytime.
Excellent. We are recording this, so I've got record of that. Dion, let's maybe focus to you first of all, maybe just a last question or a last sentence from your side.
Yeah, I think we're very excited, and it's a seriously daunting task. I think you've heard so many, most of the discussion today was about the different components that occur within this ecosystem. And the pinball example is just such a beautiful analogy. And we need to try and coordinate this, that we don't have the bouncing around, and that we actually have meaningful interventions with meaningful outcomes. So if you look at this, it can be quite daunting, but we're seriously taking this in an approach to say, let's create that ecosystem. How do we enable that? What technology is required? And how do we slowly but surely navigate into this to make meaningful difference? We've picked diabetic care as our primary focus. And it's exciting because we're not just looking at this in South Africa, but in other African countries and in the USA. And I think we can really show them a thing or two about how this is done and how this can be coordinated and empowered through technology. We don't profess to be the clinical experts. We don't profess to be the actuarials. We don't profess to be the training experts. But what we can do is create that environment where all these experts can come together and actually create an ecosystem that, in fact, has meaningful difference and change and impact on patients' lives. And that's really what we're doing. And we're going to do it slowly but surely. And we're really looking forward to many practitioners putting their hand up to be part of this journey, because this shouldn't be done by an administrator or a scheme or a Department of Health. I think this should be sitting with the professionals, defining how they navigate through this and their contributions to the ecosystem. That's where it should be landing. So, you know, we often see things happening in the ecosystem and in health that it's a result of leadership vacuums. And we're stepping up to say, let's show some leadership here and show what we can do as healthcare practitioners.
Excellent. Thanks, Dion. Prof, I'm leaving the last word to you.
No, I think we are going to end with a COVID thing, because COVID has been a black swan event. And if you ever read that book, you will know that we've got to come out of this stronger, not the same. We're not going back to the same. We're coming out stronger. And I think this is the way forward. This is visionary. And I think we all need to start looking to the future to do things differently.
And
for our patients, for ourselves, and for the world.
Wonderful. Thank you so much for those last words. 2 minutes overtime. I do apologize for that. Thank you again for joining us all. We hope to see you all here next week. Have a fantastic evening and look after everyone around your circle. Until next week, folks, take care. Bye-bye.
Thank you very much. Bye-bye.